Okay, I am working in Amrita Institute of Medical Sciences and Research Centre. So this is probably the biggest hospital of Asia, 2600 bedded. Proud to be here, and the journey has just started. So I also happen to be an associate professor by the virtue of the institution. We are a medical college. Our first batch has come and the second batch is due, and maybe we are starting with DNB, and next year we'll have MD and MCH also. And as far as the molecular biology department, which I am heading, is concerned, we have advertised PhD seats in the molecular biology department. And in fact, since I've come here, the window is open. Maybe just 1 or 2 days we are going to have, it's been postponed to 23rd, the interviews. So in case anybody is interested, so they can apply. And we will soon also have fellowships in molecular. Okay, with that, today's topic. The topic is molecular landscape of familial cases in lung cancer. And first of all, I like to thank Dr. Kumar, Dr. Anuradha, Dr. Pratik for this opportunity. And since she said that I have just shifted, so I don't have much data. And familial lung cancers as such are very rare. So, but fortunately, in the last 3 months, I have had 2 cases. Okay, so this is my first case. So this is a case of non-small cell lung cancer where we did a comprehensive genomic profiling, and why we did it, the patient was ALK positive and was not responding to treatment. So one generation after another generation, and then finally comprehensive genomic profiling was done. And what we found, there was, of course, the ALK fusion was there, and along with this there was a HRR gene NBN mutation which was there. And just looking deeper into the mutation profile, what I found was NBM was there at a VAF of 58%, but there was another Fanconi anemia and some also included in the HRR genes, because there is no clear-cut definition of HRR genes. So is the FANCC gene mutation, splice site mutation, which was 82%. So okay, and along with that there was a VUS, please mind the mistake, so in the BRCA1 gene, which was 56.5%, and there was also ALK copy number there. So I was wondering why the patient is not responding to treatment. So I thought maybe ALK, and then I looked at the VAFs, and I was more inclined that probably FANCC is germline. NBN, I was like, maybe could be, but because of the 82%. And but I usually in our comprehensive profiling don't mention the LOH and GIM score, which is analogous to HRD score in the lung cancer cases. But since it was high and the software calculates that, so I did mention it, and it was a high LOH. So we also did a germline profiling for this patient. The patient was offered a hereditary 146 comprehensive genome panel, and we found that the patient had a germline NBN, FANCC, and BRCA1 VUS. So all of the 3 were there. Okay, the patient, it was discussed in tumor board. They started with rucaparib, but unfortunately 1 month, 2 months, some response, no response, and finally I think 4.5 months after the patient died, the patient did not respond. So this is one case. This is another case which was not done at our institute, but it came in the tumor board, and it had 2 EGFR mutation, one with a VAF of 56%, the canonical L858R, and the other one was 776 mutation. So knowing by this history that this could be a germline, we took the blood sample and did a Sankar confirmation to prove that 776 was germline. Okay. So, but these are rare occurrences, these don't happen. So what does the literature say about the germline or the familial mutations in lung cancer vis-a-vis other tumors? So if you just have a look at this review, so it apparently appears that the thoracic malignancies, especially the mediastinal germline tumors, have lot of germline mutations compared to the other tumors. Ovarian cancer, we know, has lot of germline mutations, but if you just look at non-small cell lung cancer, there is hardly 2 to 3%. Some studies have reported more, and there are germline mutations reported in small cell as well as mesotheliomas in the thoracic malignancies. But though the study numbers are very small, mediastinal GCT are known to harbor a lot of germline, but I don't think most of the clinicians do get any germline testing with the mediastinal GCTs. So, but you should keep that in mind. It could be a possibility. But these numbers, I have just looked up the literature. They are like maximum studies of 400 cases. So, but there are 30 cases, 40 cases. So, but yes, you should keep that in mind. So coming to the non-small cell lung cancer, so usually the pathogenic germline mutations are between 3%, but these are whole exome studies which have been conducted in different parts of the different continents of the world, and you can see in the European continent they have been reported to be 15%, and Asian 5.9, and the North American 4.3. But if you look at the number of the cases in the European population is far lesser, 134 compared to what they are in the European and the American and the Asian population. So what I presume, though there may be some populations which inherently have a lot of germline mutations, overall the incidence may be around 3 to 5%. Okay, so these are the list of germline mutations which are possible in non-small cell lung cancer and which are known: EGFR, TP53, and the Lynch syndrome, and the HRR genes. So just a quick wrap for all of them, since only I have few minutes. So considering the EGFR germline mutation, it is reported around 1%. The commonest is T790M. So that is the commonest, and the lifetime of it's usually an indolent tumor which is reported, and the young patients are young at diagnosis, and they usually have a concomitant somatic EGFR mutation. And at radiology there are multiple lung nodules which are present, and the response to TKIs is heterogeneous. Osimertinib has shown some response in many cases. So the key is that multiple nodules when you find in a lung cancer, and you can start clinically thinking about that, and of course there is a concomitant mutation along with that. So then is the Li-Fermani, again very rare. All these mutations have concomitant EGFR mutations, and usually patients are younger, and it is unlike your conventional TP53 mutation which is coming with your EGFR. This may not be initially the mechanism of resistance. So if it is germline and you have a high VAF, and it may not be the mechanism of resistance. That's what been reported in the literature. And though later on there may be another one which can come. So then the MMR genes, the Lynch syndrome genes, so these are very less. Of course, we are not usually testing the lung cancer for Lynch syndrome. MMR testing is not done. And in the literature also, no second hit as seen in the colon cancer has been reported. These could be just casually co-occurring events, and they are also not known to respond to immunotherapy. So if you find them and it doesn't fit in, so it will not behave like a MMR tumor. And the commonest ones are, of course, the HRR gene. The incidence has been reported maybe 2 to 9%. And of course, BRCAs and ATMs and JEC2 are common. They are in never smokers. And in the non-smokers, the radon 222 is known to be a carcinogenic, and which has been reported by WHO, and these effects are enhanced by if you have the hereditary mutations in these HRR genes. So this is a large study. So around 90,000 patients of non-small cell lung cancer, where CGP was done at Foundation. This is a European studies, and what they found is in European population, since it's a European study, so the maximum was the European population, and most of them were adenocarcinoma, and the smoking signature is also not as much seen, and the distribution of mutations is all the mutations are seen. The common one, the YH1 and the CHEK2 and ATM are quite common in the European population. And if you consider, it is not different in the smoking group versus the another non-smoking group, but certain smoking populations have more of ATMs, BRCA and FANCA. And the driver mutation, not only the EGFR, all driver mutations from MET exon skipping to ROS, BRAF, KRAS and RET fusions and amplifications, NTRK also can be seen along with these germline variants. So these are various mutations which are seen, and the treatment wise, there is doubtful response of PARP inhibitors, and alone or in combination with chemo or TKI, most of the patients don't do well. So, and unfortunately, most of the studies have not reported the data about the biallelic loss of these pathogenic mutations. So we really don't know. Okay, then small cell, again HRR genes are more common. There is more likelihood of platinum sensitivity compared to the non-small cell lung cancer. And pleural mesothelioma, of course, it has more pathogenic germline variants, and along with the HRR, there are BAPI1 mutations which are common, and rarely TP53 and MMR are seen. BAPI1, they are young patients, they could have multiple tumor, they have indolent courses, they have a better survival, and now this EZH2 inhibitors in trials are also have shown to control the disease. So that is what is known. And the other germline mutations, unlike your non-small cell lung cancer, there is more response to PARP inhibitors in your pleural mesotheliomas. And with that, the take-home message is, wherever possible, try to do, if the money permits, of course, do a comprehensive genomic profiling. And when you are excited about the driver mutation which has come, just look at the gene which is next to it, the accompanying gene. It may be a pathogenic germline variant. Just be conscious about it. That's it. Thank you.
Yeah. Thank you, Doctor. Only one question, Pratik. Yeah.
In your experience, how many of the baseline T790 turn out to be germline T790?
I have seen just one. Like, I've seen many, GCI, but I have seen just one. But like, I don't know their families. Dr. Oxnard has reported of T1790M, and they say 23% of them in EGFR. Like, but I have not seen.
So majority of the baseline are truly baseline somatic, but not the germline.
No, I have not seen. So, but I have seen others. I don't know. I have seen more of the other germline 770, but I have not seen. Maybe, sir, you can tell how many T79 germline you have seen.
Yeah.
I think so. We can only say it on the basis of somatic testing and the VAF, and then they interpret.
Yeah.
Problem is that we have not done germline part separately to see that you do germline testing and then comment. So that becomes a challenge. But yes, pretty rare.
In NGOs, maybe you can you get a hint there. So yeah.
Thank you, Dr. Moushumi.
Yeah.
I think you can just.
No, LOH was how much? 50%. Okay. And any gene HR or anything? Nothing.
I think we will discuss the case later.
Yeah. Thank you. Thank you.